Today we are going to continue straightforward and start on the stomach. So number one, the location. You can see the location can be described based on the planes that you use. If you use these two planes that divide the abdomen into quadrants, you can say that it's located largely in the left upper quadrant, as you can see. Then abdominal regions. If you use the abdominal regions using the other four planes, you can appreciate that it's going to be largely within the epigastric region. Okay, but of course some part of the stomach extends partly into the left hypochondriac region. So that's the anatomical position, the location of the stomach. The size of the stomach vary, the shape varies, the position can vary in different scenarios. For example, if the patient is breathing in, the stomach is going to be pushed down slightly by the diaphragm. Okay, and once the patient relaxes while breathing out, the position of the stomach can slightly be elevated slightly. If it's empty, of course, the position is going to slightly be it's going to slightly differ as opposed to someone who has just taken a meal. If a patient is in a standing position or an erect position, the stomach is going to be slightly displaced down into the umbilical region. If the patient lies on his or her back in a spine position, this stomach can be within the epigastrium largely. If someone is, let's say, if someone is slim or has a slender physique, or what we call an asthenic physique, of course such individuals have a longer abdomen. Okay, and obviously that accounts for the low position of the stomach in such individuals. It's going to be slightly low in position, and it's going to almost be vertical in orientation. Someone who is who has a heavy body build, or what we call a hypersthenic body build or body habitus, the stomach is going to be in the epigastrium largely, because such individuals have a shorter abdomen. Okay, so there are many factors that can dictate the position of the stomach. You shouldn't always cram that it's in the epigastrium. Okay, you just have to know how that structure of interest looks like, the relations, so that you can easily tell that, oh, what I'm looking at is the stomach, not to just cram what the textbook gives you. Okay, so the surface anatomy of the stomach can be seen in this slide. By surface anatomy, we mean which landmarks. Are there landmarks that you can use to describe the different parts of the stomach? Yes, there are landmarks, and these landmarks are bony cartilaginous landmarks. Okay, you all know the costal margins. We have the right costal margin, the left costal margin. So your stomach is going to be situated posterior to the left costal margin. Of course, this is true in someone who is lying on his or her back. So it's going to be it's going to be behind the left costal margin. You can see the level of the fundus. The fundus is going to be at the level of the rib number 5, or you can say the level of the 5th costal cartilage. Okay, the cardia is going to be at the level of the sixth costal cartilage. You can see the greater curvature is going to extend towards the left side. The lesser curvature is also extending to the left side. And the whole of this central portion, we shall let us see that it's the body, it's going to be behind the left costal margin. So basically, these landmarks here, they can sometimes guide you as you're scanning for the stomach. Okay, some part of it is found behind the ribs, so of course you expect some rib shadows as you are scanning for the stomach, because the fundus and part of the body are found behind the ribs and the costal cartilages. Okay, so that's important. The parts of the stomach, broadly there are 4 parts of the stomach. The first part is called the cardia. Okay, that's the part that is in continuity with the esophagus. Above the level of the cardia, we have this expanded portion that you can call the fundus. So below the fundus, of course, we have this central portion that extends up to this angle here. This angle where you see the lesser curvature here. This is the lesser curvature here. So there is some angulation here. So where this angulation is, that's where the body is going to stop. The body, or the corpus, is this part that is labeled number 3. And then the whole remaining portion of the stomach, this is the pyloric region of the stomach. And that pyloric region is going to be divided into 2. There's a wider portion and the narrower portion. The wider portion is the pyloric antrum. Then the narrower portion that is continuous with the duodenum, that's the pyloric canal. And at the end of the pyloric canal, there are some circular muscle fibers that form what we call the pyloric sphincter. These are going to be regulating gastric emptying, so that the contents in the stomach can enter the duodenum. So the body, the fundus, the cardia, the fundus, the pyloric region, those are the 4 parts of the stomach. Okay, so the cardia, the fundus, the body, and the pyloric region. Okay, so usually, radiographically, these parts can be appreciated. This here you can see a radiograph showing you the stomach. Of course, there are some peristaltic waves of contraction within the stomach, but of course you can see, of course, this will be the body here, and here we have the pyloric region, and then up here, this dome-shaped upper part is the fundus. Usually the fundus is going to contain some gas, and that's why it's appearing dark in this image. Whenever you're swallowing, sometimes you take in some gas, some air. That air is going to settle within the fundus. Remember, air is less dense than the fluid content, so it's going to rest within the fundus. This air or this gas sometimes can be coming from the action of bacteria. Bacteria in your gut usually carries out fermentation, result into gas production. So that gas sometimes can come and settle also in the fundus here. That's why usually it appears darker radiographically. Okay, so you can see again the four regions here, all the four parts. We said that portion of the stomach that is continuous with the abdominal part of the esophagus is the cardia. Above the level of the cardia, this dome-shaped part is what we call the fundus. Below the fundus, this large central portion is called the body. It's going to continue up to the level of the angular notch. You can also call it the pyloric part of the stomach, being divided into two. There's a wider part, the pyloric, continuous with the duodenum. Okay, inside your stomach, of course, there are some ring-called structures, or you can call these gastric folds or gastric rugae. Of course, these gastric rugae are just elevations of the inner layer of the stomach, and that layer is the mucosa. So usually that mucosa is going to be thrown into folds. It's going to appear wrinkled, and these folds can stretch. Whenever you eat, let's say, large meal, these folds can stretch to allow your stomach to easily expand. Okay, so shall talk more about the mucosa later, but that's what I wanted to show you here. The mucosa is going to form gastric folds, or what we call gastric rugae, and actually these can also be seen very well on X-ray. Okay, the patient has got let's say peptic ulcer disease, changes are going to be seen within this gastric rugae. Remember, patients with peptic ulcer disease are going to present with wounds within the gastric rugae, within the gastric mucosa. So these changes can all be well appreciated. The layers of the stomach, there are four, just like how we saw in the esophagus. There were four layers. There are also four here. The innermost layer is the mucosa. Deep to that, or external to that, we have the submucosa, the muscle layer, and the serosa. Though within the esophageal wall, the outer layer was the adventitia. Okay, but for the stomach, up to down towards your large intestines, the outer layer of the gut is going to be the serosa. So, of course, the serosa is just for protection, separating your stomach from the surrounding structures. Okay, that wasn't the case for the esophagus. Remember, it was lined by the adventitia as the outer wall, and that outer wall was just had many fibers that were connecting to surrounding structures. But for the stomach, for it is sealed by the serosa. To be specific, you can also call this the visceral peritoneum. Okay, it's going to seal off the stomach and somehow limits the spread of infections from other parts to the stomach, or from the stomach to other parts. But of course, last time we said that if someone has a chronic ulceration, it's possible for ulcers to poke holes within the wall and allow stomach contents to leak into the abdomen in chronic states. The muscle layer is just a layer that's going to be allowing contraction. We have the circular muscle fibers, the longitudinal and the oblique muscle fibers. For the esophagus, we only have the circular and the longitudinal, but here we are going to have an added layer, which is the oblique layer of muscle fibers, because we need more muscle fibers that are going to allow more contraction, so that the contents that are here can be forced to go through this narrow gap here, the pyloric orifice, so that they can enter the duodenum successfully. The submucosa is going to be filled with loose areolar connective tissue that has blood vessels, lymphatics, and nerve fibers. The mucosa of the stomach is highly modified to form what we call gastric glands. You're seeing these longitudinal extensions of the mucosa. These are gastric glands. These glands are made up of several types of cells that are going to be producing particular products that will form, or that will be part of what we call the gastric juice. The juice that will be emptied out via these holes that we call the gastric pits, so that juice can enter into the lumen to aid in digestion. To be specific, the gastric glands have got cells like the chief cells. What's the function of the chief cells? What's the function of the chief cells?
The chief cells secrete pepsinogen and gastric lipase.
Okay, so they help in secretion of pepsinogen and gastric lipase. Okay, then the parietal cells, they produce. Anyone to tell us what the parietal cells will give us?
They secrete the intrinsic factor which will help in the absorption of vitamin B12.
That's good. So the intrinsic, the parietal cells, they are going to produce intrinsic factor, and this intrinsic factor is just a special type of protein that will help in binding with the vitamin B12. Let's say if you eat some green leafy vegetables, your body is nourished with vitamin B12, and that vitamin B12 in your intestines, for it to easily move to enter your blood, there should be an intrinsic factor, a special protein produced by the parietal cells. That intrinsic factor to allow this vitamin B12 to be easily absorbed. Okay, so that's why patients with long-standing cases of gastritis or peptic ulcer disease, some of these cells can wear off, and over time there will be reduced formation of intrinsic factor, which can contribute to anemia. Why? Because normally the B12, after being absorbed, it goes to the bone marrow and helps in blood cell production, red blood cell production. So without it, the red blood cell count can reduce, contributing to anemia. The parietal cells also produce something more. What else is produced by the parietal cells?
It also secretes hydrochloric acid.
Okay, what's the function of the acid?
Is to acidify the food, and then it also stops the action of salivary amylase.
Okay, so the acid will can help in killing the bacteria. Let's say you're eating food that is contaminated with bacteria. That bacteria can easily be killed by the acid in your stomach. The acid will also help in denaturing proteins. Remember, proteins are large complex biomolecules. So whenever you eat a protein-rich food, those proteins are going to be denatured by the acid so that they can later easily be acted on by the enzymes. Okay, so the acid also will help in activating pepsinogen so that pepsin can be formed to help in protein breakdown. So there are many cells. That make up the gastric glands. You can read about them more. And of course, this is all part of physiology, and you can read about how gastric juice secretion is regulated. There is a lot to that. Okay, that's just physiology, and it's quite direct. Okay, so the layers of the stomach can further be seen here. You can see the outer layer is the serosa, as we said. As we go deep, we have the muscle layer here, what we can call the Muscularis propria. Okay, or you can also call it you can just simply call it the muscle layer, that's okay. And we said it has muscle fibers. Okay, deep to that, there is this submucosal layer that has connective tissue and the blood vessels. Deep to that, we have the mucosa. The whole of this is the mucosa. But this mucosa, it's going to have, if you look closely here, the mucosa, it's going to be made up of some epithelial lining, the simple columnar epithelial cells that will extend to form the glands that we've been talking about. This very layer, it has got the lamina propria. This lamina propria is just made up of connective tissue. Okay. We have the muscularis mucosae. This is the thin muscle layer that will help in squeezing these glands so that they can empty their secretions into the lumen of the stomach. So sonographically, yes, here anatomically we are seeing that there are 4 layers, 1, 2, 3, 4, okay, but sonographically this also appears to be like a distinct layer, but yes, we know it's part of the mucosa, but this thin layer of muscle fibers tends to appear as if it's another layer. That's why you're seeing 5 here. The serosa, the outermost, the muscle layer, this, the submucosa. Then we have the muscularis mucosae, that thin muscle layer. And then we have the mucosa here. But remember, this anatomically is part of this. But since this superficial part of the mucosa has a different structure components, and then these are muscle fibers, these structures are going to appear differently on ultrasound. So that's why we are calling just this the mucosa, and then deep to it, that thin muscle layer can also be taken to be like another layer, but technically it's part of the mucosa. These layers appear differently on ultrasound. Of course, you can see the serosa, it will appear bright, or what you call hypoechoic. Don't mind about these terms right now, you will get to know what they mean, but just know that it's going to appear bright. Okay. Deep to that, we have the muscle layer. Those fibers make it appear dark sonographically. Deep to that, we have the submucosa. It has connective tissue, blood vessels, all that make it appear bright. And deep to that, we have the thin muscle layer, which is a hypoechoic. It's dark. Then deep to that, we have this mucosa. It's made up of the epithelium, as we said. Then, of course, the lumen, which is the central passageway where food is going to be passing. Okay, so these very layers form the so-called gut signature. In ultrasound, you learn that this is the so-called gut signature. Okay, made up of these 5 layers. So when you continue down in the small intestines, large intestines, we shall see that these layers will be almost the same in appearance, as we shall later see. There will be just a few differences. That's why we call this the gut signature. It is the pattern of layers that are going to be seen from the stomach downwards. So you can see the serosa, as I said, it's going to appear whitish. Deep to that we have the muscle layer. Deep to that we have the whitish submucosal layer. It appears like that because of the loose areolar connective tissue with the neurovascular structures. Deep to the submucosa, we have the Muscularis mucosae, as you can see here. Deep to the submucosa, we have the Muscularis mucosae, okay? And it's going to be appearing dark, okay? But also close to it here, we have some glands that are going to make all this layer, zone appear black, and that's why this can also be called the deep mucosa, as you see it being labeled here. It's the deep mucosa, and then the epithelium of your mucosa forms the superficial mucosa, which will appear bright, as you can see. Okay, so once again, the serosa is outermost. As you go deep, we have the muscle layers. As you go deep, we have the submucosa, which is bright. Then this dark zone with these muscle fibers and a few glands and lymph nodes will make this zone to be dark, and it's called the deep mucosa. Then as you go towards the lumen, which there will be another thin bright layer, which is the superficial mucosa, made up of mostly the epithelium. Okay, so those are the layers of the stomach. In this image, you can still see the layers to appreciate the gut signature. So he said, if you can see in this image here, this is a cross section of the stomach. This is the liver, this is the abdominal wall. We shall later see that there is a close relationship between the stomach and the liver. And this is a cross section of the stomach here. To magnify this portion here, you can see your layers. The serosa, it's whitish, that one there. The muscle layer is dark. Deep to that, you have the submucosa, which is bright because of the loose connective tissue. Then deep to that, to be specific, said we have the Muscularis mucosa. And what else makes this zone black is the gastric glands with some lymph nodes. Then deep to that, there's this bright superficial layer, or the superficial mucosa, to be specific. Then this is your lumen. So those are the layers of the stomach. I've showed you all this because usually the stomach is mostly examined sonographically, and you always review these layers on ultrasound. Okay. The relations of the stomach can be seen in this slide. The anterior relations, here we mean structures that are in front of the stomach. Of course, the abdominal wall, the anterior abdominal wall, it has been removed here, but it's going to be in front of the stomach. The left dome of the diaphragm is going to be anterior to the fundus of the stomach. The left costal margin, that one there, it's anterior to your stomach. The left lobe of the liver, that one there, this is anterior to the stomach. You can also see it there. It's anterior to the lower part of the esophagus, but also to the stomach. Okay, so once again you can see again the relations here, the diaphragm, the left lobe of the liver, the abdominal, which has been removed. All those are structures anterior to your stomach. Posteriorly, Of course, there are many structures, as you can see here. This is your stomach. Behind it, you can see a lot of structures. In this image, you can see your stomach, and we can see that beneath it or behind it, there is a space that last time we called the lesser sac. What was the other name of the lesser sac? Anyone to remind us?
The ommenta bassa.
The ommenta bassa. Okay. So the ommenta bassa lies behind your stomach. Okay, so beneath the ommenta bassa, we have those other structures that you see there, the pancreas. Okay. Of course, there are these vessels that run along the pancreas. There is this artery going to the spleen. It's called the splenic artery. There is this vein coming from the spleen there behind your pancreas, the splenic vein. You can see this is the left kidney. Part of it is going to be behind the stomach. On top of this kidney, we have the left adrenal gland, or the left suprarenal gland is also going to be behind the stomach. Those structures, those are the ones that you can obviously see to be behind the stomach. Others, we shall see them as we continue. So this image further shows you the stomach. If you lift it, of course, there is this ommenta bassa and many other structures that are behind the stomach. The pancreas, we've mentioned it, the left adrenal, the left kidney, okay, the transverse mesocolon, part of the transverse colon, they are going to be behind the stomach. And very many vessels, the splenic artery going to the spleen, the splenic vein coming from the spleen, all those are going to be many features or structures that will be situated behind the stomach. All those features of importance because they are routinely seen during the scanning of the stomach. So let's imagine we are positioning our probe in the epigastric region in a sagittal manner, as you can see here, or in the longitudinal plane or sagittal plane. In such a plane, of course, if you're to scan for the stomach, of course, you're going to appreciate the antrum. Remember the antrum, the pyloric antrum, it's almost in the midline, okay? The fundus is on the left, the body is on the left, and as we get close to the midline, we shall have the pyloric region, and this is your antrum around there, the midline. So in such a plane, of course, you're going to see the liver, you're going to see the pancreas, which is behind. Okay, and of course, since the plane goes through down, the duodenum and other vessels can also be appreciated. But close to your stomach, the liver is anterior, the pancreas is behind. All those structures can be appreciated. For example, in the same orientation, in sagittal manner, we can see the antrum of the stomach, as I told you. This is the abdominal wall. Okay, this is the liver, the left lobe there. Okay, in front of the antrum of the stomach. This is the antrum of the stomach. Okay, behind the antrum of the stomach, we have the pancreas. That's your pancreas there. Okay, as you go more posterior, of course, there is a superior mesenteric artery that is coming from the abdominal aorta. You see in this image here, this is your abdominal aorta. There's a branch that we call the superior mesenteric artery. This one, it's more posterior in position, not close to the stomach. So you can see the direct structures that are posterior to the stomach. We've seen the pancreas in this image, and then anteriorly, of course, we have this is the abdominal wall, and some part of the left lobe of the liver. Okay. The blood supply of the stomach can be appreciated just after a small review of how the gut is normally supplied during development. During development, of course, as I told you yesterday, we have the foregut, we have the midgut here, okay, the hindgut. Normally during development, the foregut is going to be supplied with a special artery that we call the celiac artery or the celiac trunk. It's going to supply blood to the foregut, and it will be the very artery that will supply blood to the structures that are going to be derived from the foregut. The structures like the liver, the spleen, the stomach, the pancreas, part of the duodenum, this lower part of the esophagus, all these structures, they are going to be supplied by the celiac trunk because it was the same vessel that was supplying blood to the foregut. So obviously it has to be the same vessel that will supply these structures that are derived from the foregut. Okay, so you can see the celiac trunk here. It's a normal branch it's a short vessel that comes from the anterior surface of the abdominal aorta, and normally divides into three to give you the vessel going to the right. This is the common hepatic artery. It's going to the right. This vessel that has veins in it going to the left. This is the splenic artery. And then this tiny vessel going upwards, rolling over the lesser sac, the lesser curvature. This vessel is the left gastric artery. Okay, so all these vessels are going to contribute towards the supply of blood towards the different parts of the stomach. You can see the splenic, as it goes towards the left, towards the spleen, it's going to give off what we call the short gastric arteries. These can be around 4 to 5. They're going to come and supply blood to the fundus. Then this splenic, before entering into the spleen, it's going to also give off what we call the left gastroepiploic artery. It's going to come and roll over the greater curvature to supply blood to the greater curvature of the stomach. Then, as you can see, your common hepatic, the common hepatic is going to divide into, it's going to move towards the right side, and as you see the word hepatic, it means it's going to the liver. But before reaching the liver, it has a branch that we call the gastroduodenal. Gastroduodenal, it means this artery will supply blood to the stomach but also to the duodenum. So it will extend down and give off branches to the duodenum, but also it will continue as the right gastroepiploic, which will roll over the greater curvature and anastomose with the left gastroepiploic, so that all these two can always allow continuous supply of blood to the greater curvature. Then your left gastric, it's a branch also from the celiac trunk, and it's going to roll over the lesser curvature, supply blood to the lesser curvature of the stomach. And it's going to anastomose with a very small branch given off by the common hepatic, a branch that we call the right gastric artery. Some sources state it's a branch of the common hepatic, but also other sources can say it's a branch of the hepatic artery proper. The hepatic artery proper, it's that artery that is destined to go to the liver, to nourish the liver, to give off the right gastric that will come and roll over the lesser curvature and anastomose with the left gastric, so that these two can form this loop that will always allow continuous supply of blood to the lesser curvature of the stomach. So that's how the stomach is supplied with blood. It has an extensive arterial supply, which is good, because it is very important during digestion. This is a detailed picture showing you the three branches of the celiac trunk. The one going to the right, remember it was our common hepatic. You say that before going to the liver, it has the gastroduodenal artery that will come and give off the right gastroepiploic. This gastroepiploic can also be called the gastroomental. Why? Because the greater omentum attaches on the greater curvature. So this artery can also be called the gastroomental, the right gastroomental. Then we said your common hepatic is going to become the hepatic artery proper that will be destined to go to the liver, but before reaching the liver it has a branch that we call the right gastric artery that will come to anastomose with the left gastric along the lesser curvature. Then the splenic, you can see it has a unique course. It has bends. It is tortuous. It has bends within it. Because we know that normally the stomach has to expand, so it has those bends so that even though the stomach expands, it's not overstretched. So that's why it has those bends along its path, which is normal. Okay, it's going to the spleen, but also I said it's going to give off short gastric arteries and the left gastroment or the left gastroepiploic that will come and anastomose with the right gastroepiploic to allow continuous supply of blood to the greater curvature of the stomach. Okay, so that's the arterial supply. The veins that drain the stomach are also direct. Of course, we shall have the short gastric veins that will empty into the splenic. We shall have the left gastromental vein or the left gastroepiploic vein that will empty into the splenic. And of course, the splenic, after receiving this blood, is going to continue running posterior to the stomach. And as it runs posterior of the stomach, it receives some more tributaries from the posterior wall of the stomach. You can see those tributaries are entering it from the posterior wall of the stomach. And as it continues towards the right side, it's going to receive the so-called inferior mesenteric vein. This is draining blood from the large intestine. So it's going to join it. After joining it, our splenic will continue with its journey. And after the splenic reaching the posterior aspect of the neck of the pancreas, this is your pancreas, so around the neck there, behind, the splenic is going to join with the superior mesenteric vein, which is draining blood from the small intestines. These two are going to confluence and join to form the hepatic portal vein, or the portal vein, which will take this blood to the liver. This blood has nutrients and it has to be taken to the liver. The portal vein, after being formed, it will receive the left gastric vein, as you can see, and the right gastric vein. All these will empty into it. Okay. The superior mesenteric, before joining the splenic, it's going to receive the right gastroomental, as you can see, so that this blood can go eventually to the liver. So this blood in the portal vein, yes, it is venous blood, but it has got nutrients from these structures on the digestive system, and that's why it has to go to the liver, because that's where assimilation or metabolism will take place. Something small about peptic ulcer disease. We say that ulcers, in a layman's term, they are like wounds. They are wounds that form in a particular part of the body. These wounds, they are going to form, in most cases, they are going to be more likely to form along the lesser curvature, the antrum, and these ulcerations can extend and also affect the first part of the duodenum. Why are these ulcerations more on the lesser curvature? Remember, we have what we call the gastric canal. This is the gastric canal. It's a pathway where food is going to mostly be passing. Once you swallow, this food is not going to roll over to the other side. It's going to take that very path. Of course, because of gravity, it will take that path to enter the gastric canal, and because it's going to be mostly rolling over that part, this will be the portion that will be more affected with ulcerations. The lesser curvature, the area of the antrum, and these ulcerations, I said they can extend to affect also the duodenum, the first part of the duodenum. Okay, so that's what we call peptic ulcer disease. The causes, it could be this injury of the mucosa to form the wounds could be brought about, let's say, by an infection. There's what we call Helicobacter pylori. This germ can cause erosions or wounds in the mucosa of the stomach. If you use non-steroidal anti-inflammatory drugs like aspirin, diclofenac, and many others, those drugs tend to reduce the rate of mucus production within the stomach. Remember, along the gastric glands, we have some mucus neck cells that are supposed to always produce mucus. So the rate of mucus production can be reduced if you take such drugs. Without enough mucus, the walls are going to be exposed to the acid and they can be burnt to form the wounds. If a patient has chronic pancreatitis, or if a patient has a bile duct disease, this can easily result into injury to the wall of the stomach, or it can just simply be a reflux towards the stomach, though this is not so common. The most common cause of this germ, the H. pylori, but also use of these drugs. This is also seen in people who chronically take alcohol, people who smoke, people who overuse steroids. These people have a higher chance of what? Of having peptic ulcer disease. Okay. Symptoms, of course, since the stomach is largely in the epigastrium, you feel a burning sensation within the epigastrium. Maybe some changes in appetite. Usually, in long-standing cases, these wounds can poke holes. They can extend and erode all the layers of the stomach and lead to what we call perforation. Perforations are like holes that will form through the wall of the stomach to allow leakage of stomach contents within the abdomen. Those are perforations. They can form in long-standing cases of peptic ulcer disease, which is not being treated or managed. Of course, it can lead to internal bleeding. This can contribute to the anemia that I talked about. And also, over time, those wounds can tend to become cancerous. Okay, so usually these ulcers can be diagnosed using endoscopy. And in endoscopy, basically, I told you yesterday, there is a surgical instrument that's going to be inserted into your upper GI with a camera that will be taking pictures of the stomach lining. Okay, But there are some patients that may not tolerate this, and it's also expensive. So ultrasound can be a non-stressful procedure that can easily help in diagnosis of these ulcers. On endoscopy, of course, if someone has a gastric ulcer, of course that wound or that erosion can be well appreciated. And usually whenever such erosions exist, the surrounding area will be edematous, or there will be edema that will be surrounding this erosion. This edema is because of the inflammation that is going on because of the mucosal injury. Okay. Ultrasound can also be a good tool that can be used to confirm ulcers. Okay, you can see gastric wall damage here. This is your stomach, so you can see gastric wall damage here. But also you can see because of the inflammation, you can confirm fluid around this part of the stomach here. This darkening is just fluid. This fluid is because of the inflammation that is going on within the stomach. So ultrasound can help in the diagnosis of these conditions easily. Then there is what we call hypertrophic pyloric stenosis. This, as you see the term stenosis I remember talking about this term here. What does the word stenosis mean?
Narrowing.
Okay. What's the difference between stenosis and atresia? So in stenosis, there is going to be just partial obstruction. Contents can easily find their way through this small gap, but of course it won't be easy. In atresia, there will be complete obstruction because of the underdevelopment. So those two are different. So in hypertrophic pyloric stenosis, there is going to be partial obstruction or the pyloric orifice because of the what? Hypertrophy of the circular muscle fibers that are found along or that form what we call the pyloric sphincter. So that's an abnormality. Kids are born with it. This sphincter it has circular muscle fibers that can abnormally undergo hypertrophy. Okay. And once those muscle fibers undergo hypertrophy, that narrows down the gap, or what we call the pyloric orifice. And of course, such kids are going to, after birth, they are going to always present with projectile vomiting. They are going to be vomiting whatever they eat. And because of the tightness around this area, the contents are going to accumulate in the stomach and they are going to be thrown out at a very high pressure, leading to projectile vomiting. This kid will be vomiting, but the vomitus is going to be thrown some distance away. Okay, that's a unique characteristic feature of this condition, projectile vomiting. But also this vomitus is going to be non-bilious. It's not going to contain bile. We all know bile is greenish, so the vomitus is not going to be greenish. It's going to be non-bilious. That's what I mean. Because we know bile is a normal secretion that comes from the liver, and then through a certain pathway that bile finds its way in the duodenum. So you can see the obstruction is before the duodenum. So the contents that are going to be coming out, obviously, they're not going to contain bile. So it's a non-bilious vomiting, projectile in nature. This presentation is it's going to be between 4 weeks after birth and second month of life. These kids are always going to be hungry and always crying because of the hunger. Okay, even though they are fed, they are going to always be crying because of them being hungry. Whatever they are being fed is being brought back because of this vomiting. But also another interesting feature, as the hypertrophy of these circular muscle fibers go on, of course, food contents are going to be accumulating in the stomach, and these kids are going to present with a round shaped mass or an olive shaped mass in the epigastrium. Remember, contents are not leaving, they're accumulating in the stomach, and that enlarges the stomach, resulting into that kind of round shaped appearance or mass within the epigastrium. This is a very important feature also seen in these kids. Okay, so the characteristic features of this condition: 1, projectile non-bilious vomiting, and then 2, this olive-shaped mass in the epigastrium. Sonographically, this condition can easily be diagnosed. Of course, these are clinical features that can be used to diagnose, but these kids or these infants can be taken to the scan, and there are features of interest that you can easily note. So remember, this is our stomach. Okay, this is the pylorus. Normally, the length of this pylorus is around the length, or let me start with the muscle thickness. The muscle thickness that you see here is normally not less than 3 millimeters. Okay, then the diameter, if you look at the diameter of the pylorus, usually it's around 14 millimeters or less. If it's beyond 14, of course, that's a sign to worry. If the muscle thickness is beyond 3 millimeters, that's also a signal to worry. Okay, so you can see our pylorus. You can see that normally in this condition, it's going to be thickened because of the hypertrophy of the muscle fibers, as I explained. So on sonography, of course, you can see the muscle layer is thickened. It is hypertrophied. The muscle layer is hypertrophied. This is the serosa outer layer. This is the muscle layer. It is hypertrophied. And that is a very important sonographic finding in the diagnosis of this condition. So this is a longitudinal view of the pylorus, and you can see the hypertrophy very well. The lumen is almost obstructed. Okay, there is stenosis, there is some obstruction, partial obstruction. A few contents can go through, but of course just a few can go through, not everything can go through. There is that partial obstruction because of the hypertrophy of the muscle fibers. In transverse, you can still see our pylorus. You can see the muscle that has been thickened. The muscle layer that has been thickened. The lumen has been narrowed down. Okay. We said normally the pyloric diameter it's not supposed to exceed 14 millimeters, but it can be more than that in this situation. So that is hypertrophic pyloric stenosis. Furthermore, this slide showing you more important sonographic findings of pyloric stenosis. You can see this is your stomach, of course. This is your pylorus, and you can see the hypertrophy of the pylorus very well. And this pylorus, it's going to be similar in appearance. It's going to look like the cervix. You know the cervix, that lower portion of the uterus? Normally it has a slit channel, okay? And the appearance of the pylorus in this state, it's going to appear like the cervix. That's why this is the so-called cervix sign in the diagnosis of pyloric stenosis. I'm not saying this is the cervix, but it's appearing like it resembles the cervix. Then this image here, this transverse image, can show you what we already mentioned. This is the muscle layer that has been atrophied, hypertrophied, and this kind of orientation will resemble the target sign. You all know those targets that always hit in that. Your pylorus in transverse, it's going to appear like the target sign because of the increased thickness of the muscle layer. Okay, something similar to this. Okay, so those are the sonographic features of pyloric stenosis. As we wind up with the stomach, it's important to note that ultrasound of the stomach is also relevant in patients who are about to go in surgery. You all know surgery. In surgery, of course, this patient can be anesthetized, and usually whenever there are contents in the stomach after anesthesia, there's a very high chance of these contents to be aspirated. So to prevent the risks of aspiration that can lead to lung complications and even death, usually before anesthesia, usually the stomach has to be scanned to check if it's empty or full. This is also carried out, of course, in pediatric patients. You can't ask a young kid whether his stomach is empty or full. When did you last take food? You can't ask that. Obviously, scanning has to be carried out to confirm if the stomach is empty or full. In situations when you can't easily communicate when the surgeons can't easily communicate to the patient to ascertain whether his stomach is empty or full, a scan has to be carried out to confirm. Patients with an altered mental status, so patients in coma, scan has to be carried out. Patients with systemic diseases that tend to affect gastric emptying, diseases like diabetes mellitus, patients with end-stage renal disease, liver disease, or neuromuscular disease, such conditions tend to affect the muscle layer of the stomach and reduce the rate of gastric emptying. Such patients always have contents within the stomach because of the fact that these contents are going to be moving out slowly because of the underlying diseases. So in all these situations, the stomach has to be scanned to confirm if it's empty or full before the surgery, to reduce chances of pulmonary aspiration and more lung complications, because those contents can be aspirated. By aspiration, I mean these contents can easily move up through the esophagus and easily find their way into the airway, down to the lungs, leading to lung complications and even death in these patients who are undergoing surgery. So normally the stomach has to be scanned, and the stomach can be scanned in many ways, either when the patient is in supine position or when the patient is in the right lateral decubitus position. This means patient lying on his right side. So either way, stomach can easily be appreciated. Can see in either of these positions, the stomach can be well appreciated. Okay, so usually this patient is going to be lying on the right side, because once the patient lies on the right side, whatever contents that are in the stomach, they are going to come and fill the antrum. And in such a position, like the right lateral decubitus position or the spine position, scanning sagittally, this antrum can be well assessed to check if it's full or empty. So if the antrum is empty, it will be nearly collapsed, or nearly flat, or round, like a bull's eye. And that's what you're seeing here. It's empty. Okay, meaning that this patient, let's say, last had a meal like many hours ago. So it's empty. Okay. Of course, the other relations, we already know them. Posterior to this antrum, we have the pancreas. Anteriorly, we have the abdominal wall and some part of the left lobe of the liver. Okay, so here it's empty. If this patient has just taken food, there will be some solid contents within the antrum, and those solid contents, they are going to result into a shadowing effect, because solid contents may not allow the sound waves to go through to allow visualization of the posterior structures. So whenever there are such solid contents, such acoustic shadowing is going to be seen. So this is a sign that this patient has just taken solidified food particles, and this is the early stage. The patient has just eaten like a few minutes ago. Okay. Of course, after some hours, these solid food particles still they can be appreciated, but here we are seeing an heterogeneous mix of contents. Solidified food particles, they are being worked on, being digested, and you can see some features that are posterior to the stomach, meaning that solid particles are being digested within the stomach. Okay, so here you could barely see nothing because it was just after taking food. But here you can see some solidified food particles, and it's just the late stage after a few hours after food. In this image, we are seeing the antrum filled with fluid. The patient has just taken fluid contents, let's say just taken some water, any liquid. This will be the appearance of the antrum. It will be distended, as you can see, filled with fluid. This darkening is just fluid within. Okay, same relations as we've been explaining. So basically, what I'm talking about is that usually the stomach always has to be scanned to ascertain whether it's empty or full, to prevent complications during surgery. Okay, because the contents in the stomach, they have to be normally the stomach has to be empty to prevent any risks of pulmonary aspiration. And whenever there are such contents, whether liquids, whether these solid contents, they can easily be sucked out by feeding by a tube, so that during surgery there is not any risk of aspiration. Okay, so that's another good indication of gastric ultrasound. It helps in assessing the risk of aspiration after general anesthesia, after the patient has been knocked out before the surgery. Okay, so that's a little I can mention regarding the stomach. You can ask questions as I upload to cover some part of the small intestines.
Thank you, sir. I would like to inquire about the arterial supply of the stomach, because there is what I read, and they're saying from the origin from the origin, like from the celiac trunk, as it forms the hepatic artery first, which then forms the common hepatic, and they are saying the gastroduodenal artery and the right gastric artery originate from that hepatic artery. So I don't know.
No, you take this. I don't know where you got that, but understand this from these images, or it could be this. Usually from the celiac trunk, the branch that is going to the right is the common hepatic artery. This artery has a branch going downwards that we call the gastroduodenal, which is, of course, from the name, it will supply the stomach and the duodenum, obviously. And after this, giving off the gastroduodenal, it's going to continue to the liver as the hepatic artery proper. Why proper? Because it's the artery that's going to supply blood to the liver. This was the common hepatic artery, also giving rise to many other arteries, as you can see. But this is the hepatic artery proper because it is destined to reach the liver. But we said before entering the liver, it has a small branch that we call the right gastric that will come and loop over the lesser curvature to supply blood to the lesser curvature. So it's the common hepatic first, then the hepatic artery proper next. Okay, so alright, so let me upload these slides of the small intestines so we cover a few things, then we end the session. The intestines, of course, we know we have the small intestines and the large intestines. Obviously, the small intestines are called so because they have a small diameter. These have a large diameter, so that's why these are called small intestines, these large intestines. So in these few remaining minutes to 9, hopefully we may cover the small intestines. Shall see where we shall stop. Okay, so the small intestines are the longest part of the GIT. How long are they? How long is the small intestine? 5 to 6 meters long. They are quite long. So they are going to extend from the level of the pylorus to the level of the ileocecal junction. The ileocecal junction, that's a junction between the ileum and the cecum. And they are, of course, made up of 3 parts, as you can see here. And, of course, just like any other part of the gut, they are made up of 4 layers. The innermost layer is the mucosa, B is the submucosa, C is the muscle layer, D is the serosa. Simple as that. So these layers, of course, just a brief notes about them. You can see the mucosa, it's made up of an epithelium. This is simple columnar epithelium. The lamina propria, made up of connective tissue plus some lymphatic tissue, which will be very important in disease states, preventing infections. Then we have the Muscularis mucosae, that's thin muscle layer, just like as we saw in the stomach. It's also here, okay. Then we have the submucosa. Beneath the mucosa, it's a zone that has loose areolar connective tissue, a few glands, blood vessels, nerve fibers. Okay, then we have the muscle layer. You have 2 sets of muscle fibers, the circular muscle fibers and the longitudinal. Between these two, usually there is the network of nerves that we call the mesenteric plexus of nerves that will always stimulate these muscles to contract. It was the same case in the esophagus. It was the same case in the stomach. So it's the same arrangement all through up to the rectum. We have these networks of nerve fibers between the circular and the longitudinal muscle fibers. stimulating these muscle fibers to contract. Beneath the sacula, we have the submucosal plexus of nerves, what you can also call the Meissner's plexus. This will also be stimulating these fibers to contract, but also stimulating these glands to release their secretions. Okay. Then the outer layer is the serosa, and this is made up of areolar connective tissue and the epithelium, which is your visceral, which is basically going to make up your visceral peritoneum. Peritoneum that will extend posteriorly as the mesentery, which will attach your or anchor your small intestines to the posterior abdominal wall. And we say the mesentery is a conduit for neurovascular structures. We can see here that the mucosa, usually it's going to have folds. These folds increase the surface area for absorption, but that's the main function of the small intestines. When you magnify, let's say, two of these folds, that and that, you can see each mucosal fold or its circular fold, it's made up of multiple finger-like projections that we call the villi. Okay, and each villus is made up of what? Simple columnar epithelium with cells that have microvilli. These will always allow easy absorption of nutrients into the blood or into the lymph vessels. Okay, so that's the normal arrangement there. Normally, within the wall of the small intestines, we said in the mucosa, we have the lymphatic tissue. This lymphatic tissue, it's present in many other parts of the gut, but it's more abundant in the small intestines because they are more predisposed to infections. We shall see why. So they have to be abundant, and these lymphoid tissues or lymphatic tissues in the small intestines, they have a special name. They can also be called the Peyer's patches. These Peyer's patches, they normally prevent growth of pathogenic bacteria. Remember, within your gut, normally there is the good bacteria and bad bacteria. Normally, these Peyer's patches prevent growth of bad bacteria or pathogenic bacteria that has the potential of resulting into disease. Okay, that's the function of the Peyer's patches. They are part of your body's immune system. Okay. The layers of the gut, same layers as we say, the serosa, outermost. Deep to that we have the muscle layer. Deep to that we have the submucosa. Deep to that we have the mucosa. Okay, but I said the mucosa has this muscularis. Okay, and of course a zone of lymphatic tissue. These zones are going to stand out and appear different from this other part of the mucosa. That's why we shall call this the superficial mucosa, and then this the deep mucosa. As you can see here, same arrangement. Outer layer, which is A here, it is your serosa, right? B is your muscle layer, is hypoechoic, it appears dark. Then as you go deep, this bright layer is the submucosa. As you go deep, this layer labeled D is your deep mucosa, made up of the Muscularis mucosa plus the lymphatic aggregates or the lymphatic tissue, the Peyer's patches. That's why it's appearing dark and more thickened normally. Then deep to that we have the superficial mucosa that is next to the lumen, as you see there. So this is in longitudinal. If you position your probe in the longitudinal fashion on the abdomen, that's what you see, the longitudinal appearance of the intestine. If you position in the transverse fashion, you see there's a cross section of particular part of the intestine. The Peyer's patches, they are in the deep mucosa, as we have said, and they are always very important in preventing infections. And you can see them here. They are normally within the deep mucosa, and they make that layer to be thickened, which is normal. Okay, they are abundant in the small intestines. So the small intestines, we've said, divided into three. We have the duodenum, the jejunum, and the ileum. And starting with the duodenum, it takes a course to wrap around the head of the pancreas, and it's going to begin at the level of the pylorus and terminate at the level of the duodenojejunal flexure. Flexure means the bend, that bend between the duodenum and the jejunum, that one there. That's where it will terminate. And it has four parts. There is this first part that you can also call the superior part, second part that you can also call the descending part, third part that you can also call the inferior part, fourth part that you can also call the ascending part. All these are different parts of the duodenum with different relations. So usually the first part, usually it's going to be, it's going to appear widened, and that's why some texts can refer to it as the duodenal ampulla or the duodenal bulb because of the normal appearance. It's normally going to be appearing wider or round in shape. This is why it's called the duodenal bulb or the duodenal ampulla. Those are the terms that can also be used to mean the first part or the superior part of the duodenum. This part is going to be at a very high chance of having ulcerations within because it's next to the stomach. But if there are ulcerations in the stomach, they can easily extend to the duodenum in the first part specifically, as we said in the previous slides. The relations, this is your first part here, this is your first part here, this is your first part here. So your first part of the duodenum, anteriorly, it's going to be related to the liver and the gallbladder. The liver and the gallbladder. Posteriorly, they are important structures. One, it is our gastroduodenal artery. That one there, that branched off from the common hepatic, goes down to supply blood to the duodenum and later to the greater curvature. It goes down by passing behind the first part of the duodenum. The common bile duct, that one in green, also passing posteriorly. You can see it here also passing posterior to the first part. The portal vein is found behind the first part of the duodenum. That is the portal vein. We saw how it is formed. The IVC, that large vein there, is found behind the first part. So this large vein is the IVC. The small vein going to the liver is the portal vein or the hepatic portal vein. They are all situated behind the first part of the duodenum. Below it, of course, we have the head of the pancreas. The descending part, which is the second part, a few important features. You can see that it's the entrance of it's a common entrance for the common bile duct and the main pancreatic duct. Normally, the main pancreatic duct, of course, it's going to be carrying the large amounts of pancreatic juice, but normally it has to fuse with the common bile duct so that these two can later pierce the wall, the medial wall of the second part at what we call the major duodenal papilla. So since those two are piercing, that mucosa will be raised to form the so-called major duodenal papilla of the second part of the duodenum. So these two are going to be joining that second part at the major duodenal papilla. Then also you have the minor duodenal papilla. It's a small opening which is going to be an entrance point for the accessory pancreatic duct. Your pancreas has a big duct and a small duct. The big duct is the major or the main pancreatic duct. The small duct is the accessory pancreatic duct, and that has a different opening in the duodenum, and that opening is at the minor duodenal papilla. This descending part has a few relations lateral to it, or you can say first anterior to it. You can see that your right lobe extends down. It extends down to overlay it. The transverse colon, this is the transverse colon. We know that it extends to the left and it's going to cross it, okay, anteriorly. Fundus of the gallbladder can overlay it, as you can see here, okay. Then posteriorly, this is your second part. Posteriorly, we have a muscle that we call the right psoas major muscle. Hope you recall that muscle. We have the medial portion of the right kidney, but of course we know that there are vessels that are entering and leaving this kidney, and they are going to be on the medial aspect. So those right renal vessels can also be taken to be the posterior relations of the second part of the duodenum. Then also you can see the ureter. This ureter, right ureter, is coming from the right kidney, overlaying the psoas major muscle, and since your muscle is behind the second part, we can also say the right ureter is also going to be among the posterior relations of the second part of the duodenum. Okay, then inferiorly, this inferior part, or the third part, is going to be the longest, and it's going to cross, it's going to be straighted anterior to the IVC and the abdominal aorta, and it's going to be straighted posterior. It's going to be straighted posterior to the superior mesenteric artery. Where is this one coming from? It's a branch of the abdominal aorta. The abdominal aorta, we already seen that it's going to give off the celiac trunk, but also just a few inches below, it's going to give off the superior mesenteric artery, which will run on the anterior aspect of the inferior part of the duodenum. The superior mesenteric vein, it's collecting blood from the small intestines, and it's going to ascend upwards, crossing the anterior part of the, crossing the anterior aspect of this portion of the duodenum. Okay, so the relations are quite okay. I don't know. There are people who are not muting their gadgets. Please kindly mute yourselves. Kindly mute yourselves. Okay, so let's continue. Those were the relations of the inferior part of the duodenum. Then you can see the ascending parts. It's going to be extending upwards on the left side of the abdominal aorta, and most importantly, it's going to be attached to by what we call the ligament of Treitz. The ligament of Treitz is just a ligament made up of fibers extending from the right cross of the diaphragm. These fibers are going to form this ligament, a ligament that will anchor and maintain the position of the duodenum. Normally has to be in this C-shaped form because of this ligament here. Makes it to attain that C-shaped kind of orientation. Okay, so it anchors it in position. In situation when such a ligament weakens, that's why sometimes intestines can over twist upon themselves if such ligaments are weakened as we age. But it's a normal ligament that normally anchors the duodenum in position and maintains its shape. Okay. So there is a condition that we call duodenal atresia, and we say that atresia means complete obstruction due to probably underdevelopment of a particular part of the body. And duodenal atresia, I can say it's one of the most common gut atresias that presents in neonates. And the causes of this duodenal atresia can be if let's say there's a pancreas that has developed abdominally. You know, the pancreas normally it should be having a head, the neck, the body and tail, and the head is supposed to be where? The head normally is supposed to be on the medial aspect of the duodenum, but in some cases the pancreas can abnormally develop with its head abnormally wrapping around the second part of the duodenum, and such an abnormality is called an annular pancreas that is coiling around the second part of the duodenum. Such an abnormality can lead to complete obstruction of the second part of the duodenum, resulting into duodenal atresia. Then secondly, this can happen, for example, when there is failure of recanalization of the duodenal lumen. What do I mean by that? Let's look at this picture. Normally, during development of the gut, I mentioned that the lumen of the gut normally is going to initially be packed with epithelial cells. The epithelial cells will form the epithelial plug that will fill the lumen of the gut. That's normal part of development. Okay, and normally these epithelial plugs have to be digested away. They have to be dissolved so that we can regain the lumen of the gut. That process is called recanalization. We are regaining the canal or the lumen that's normally supposed to be within the gut, that will eventually allow normal passage of food. Okay, so in the duodenum, this recanalization can be incomplete. We call that partial recanalization. If it's incomplete, there will remain just a small gap that can allow a few contents to go through. That condition is called duodenal stenosis. Okay, but if there is completely no recanalization at all, obviously this baby is going to be born with a duodenum that has no lumen. Okay, and that is duodenal atresia. Duodenal atresia. Okay, so that's what I meant by saying that it can be congenital because of failure of recanalization of the duodenal lumen, or it can be because of the abnormality, the development of the pancreas. This condition, obviously you can see that it's going to predispose to polyhydramnios. Last time we said that normally amniotic fluid has to be swallowed by this growing fetus. Is normal during development, but if there is any obstruction along the gut, whether along the esophagus, the duodenum, it can limit passage of this fluid, and it can easily increase chances of polyhydramnios to result. And this polyhydramnios, we said last time that it can be bad for the baby and for the mother. For the baby, of course, this baby can be born even before end of gestation, because polyhydramnios can lead to it can induce premature contractions of the womb, leading to premature labor. But also to the mother, whenever the womb overdistends, it can result into breathing difficulties because the womb is going to be enlarging upwards, can compress onto the lungs, resulting into breathing difficulties. This mother can complain of heartburns because of the easy reflux of contents from the stomach into the duodenum, into the esophagus. So there are complications of this to both the growing baby but also to the mother. And so far, this is the second cause, second abnormality that can lead to polyhydramnios. Yesterday we talked about esophageal atresia, but now we are talking about duodenal atresia. Its counterpart is oligohydramnios. You'll see what causes that, not now, later. When you start, for example, covering the urinary system, that's when you'll appreciate it better. Okay, so this condition here can be diagnosed. It can be diagnosed even before birth by ultrasound, but also after birth. These kids can be examined by X-ray, and what you're seeing here is a radiograph showing you a condition that we are calling duodenal atresia. Because of the obstruction here, it means that there will be no passage of contents from the duodenum down to the rest of the small intestine. And we know that normally the stomach can trap air bubbles or gas within. We talked about that as we are covering the stomach. Normally that can happen. But also, because of the obstruction that you're seeing here, this upper part of this proximal part of the duodenum can be seen with some air bubbles being trapped within, and this results into what we call the double bubble sign, as described radiographically. This double bubble sign is occurring because we are seeing two bubbles: the gas bubble in the stomach, gas bubble is in the duodenum because of the obstruction. Okay, so that is a radiographic description of this case of duodenal atresia. Okay, so let me stop here. Let me stop here. When we join again tomorrow, we shall look at the jejunum, the ileum, and also cover the large intestines. So read about the rest. Read about the jejunum, the ileum, how can they be structurally, anatomically differentiated. Read about all those differences because they can guide you on ultrasound to differentiate these two. Okay. Read about the large intestines, different parts of the large intestines in detail, and how the large intestines can be differentiated sonographically from the small intestines. Okay. The blood supply, the venous drainage, all that. Read about covering that tomorrow in the morning. Are we all good?